السلام عليكم ورحمة الله وبركاته. مساء الخير، أهلا وسهلا بكم جميعا. معكم دكتور أيمن السمير. أنا حنكون المودريتور لمحاضرة اليوم. محاضرة اليوم تعتبر المحاضرة الثالثة من محاضرات أساسيات الإيكو البيزك أوف إيكوكارديوغرافي بعنوان الكارديك تشامبر كوانتيفيكيشن. إن شاء الله حيعطاها الدكتور المميز والصديق العزيز دكتور منصور خضر. اليوم حيكون معنا في الإكسبرت بانل مجموعة مميزة من الزملاء، دكتور حنان المقرحي من ليبيا إن شاء الله حتنضم إلينا بعد قليل، في دكتور أسامة القصبي من كندا، وفي مميزة المهندسة لبنى أكشاد اللي هي Diagnostic Cardiac Sonographer Certified في United States. دكتور منصور تفضل، المايك is yours.
شكرا صديقي أيمن على إتاحة الفرصة والمشاركة في هذه الندوة العلمية. Our lecture today will be focused to discuss the 2015 recommendation for cardiac chamber quantification by echocardiography in adult, an update from the American Society of Echocardiography and the European Association of Cardiovascular Imaging. So we had the initial publication was in 2005, and subsequently, as I mentioned, the update document was in 2015 because we had more data that's available. There was more recommendation about the use of strain as well as the use of 3D echocardiography. And before we dive in the document, actually, we have to mention that those values are based on multiple parameters. One of them is the standard deviation, and number two, it could be the 95 confidence interval. And number three, which is more important to us as physicians, which is based on the prognosis of the condition. For example, in the past, we use, at least outside of echocardiography field, we use the management of or definition of hypertension. For a blood pressure that's, for example, more than 140, you mentioned that patient has hypertension, but subsequently we had studies from 2015 and later in the last 1 year, actually, or earlier this year, showed the lower is better, meaning it is not just a cutoff point based on 95 confidence interval, but what is the number from which can predict a worse cardiovascular outcome. And to start with, I always say it for chamber quantification, as the name implies, we have the LV, we have the left atrium, and we have the RV, we have the right atrium as well. So there are 4 chambers. In addition to that, we had the aortic root, as well as the inferior vena cava and the superior vena cava. In reality, I call them 6 chambers, but the only one, the exception, we don't have measurement, is the superior vena cava. So to start with, the winner is the left ventricle. And to start with the measurement of the LV, initially we are going to focus on the linear measurement. Subsequently, we'll be focusing on the volumetric measurement. So for left ventricular linear measurement, the most important measurement that I want everyone to remember, which is left ventricular end diastolic diameter, which the measurement will be obtained and left parasternal long axis view through 2D echo at end of diastole at the level of the tip of the mitral valve leaflet. And that line, the green line over here, has to be perpendicular at 90 degrees to the long axis of the LV. So someone can ask, what is the importance of this measurement? In general, if you go to the initial slide over here, I can show it to you. You can see the normal LV geometry. You have transverse diameter and longitudinal diameter, and the ratio is 2 to 1. When the LV get enlarged, it is not getting lengthened, increase in the length, but usually it will become increase in the transverse diameter, and we call it's a globular heart. That's why when you see heart enlargement, you say it's a spherical or globular, mean the change in the left ventricular end diastolic transverse diameter at this level could reflect the real geometry in the LV. And that's why this parameter is very important. It's easy and quick and can tell you a lot about the geometry of the left ventricle. Again, the measurement left parasternal long axis view at the tip of the mitral valve leaflet at the end of diastole. You can measure interventricular septum thickness as well as posterolateral ventricular wall thickness. And those are the normal values. Actually, there is a range. This is for male and this is for female. The magic number that I want everyone to remember, this is for standard deviation over here, but the upper limit of left ventricular end diastolic diameter, 58 millimeter for male and 52 millimeter for female. So again, the magic number 52 millimeter for female and 58 for male. And this numbers over here indexed their body surface area. The initial number 58 and 52 are not indexed, but this one is indexed normal values. And this is what the definition of mild and moderate and severe left ventricular enlargement. Suppose if someone in elderly, sometimes we have sigmoid septum, the measurement should not be at the level of the sigmoid septum over here because it's more thickened and it can give you a false number. You go slightly below that area and you can make your own measurement. This slide was not included in the document, but it's important to remember because it's not unusual to see abnormal geometry like this one, especially in elderly. So now this is the most simple or the most important parameter for left ventricular linear measurement. We are going to move right now to left ventricular volumetric measurement. And the most important one to remember actually, biplane disc summation method. In this method, it's as simple as it is. You obtain a good view in left ventricular apical 4-chamber view over here and left ventricular apical 2-chamber view. And then you track the endocardial border at the end of diastole, at the end of systole, and make the difference between them. And the machine itself will give you automatically the ejection fraction. And this is the recommended method in that document. This is the rationale of this method, actually. If you track the endocardial border, that's why we do it in 2 views, apical 4 and apical 2s. At least at the end, you will obtain the LV. If you see those small lines over here, it's the geometry of small coins, multiple coins, around 20 coins of them. And once you obtain the coin, the height of that disc, the diameter of that disc on 2 dimensions, then easily you can calculate the volume of that coin. The summation of those small coins throughout the LV cavity, it can give you a volume. And from that volume, you are able to calculate the ejection fraction by subtracting the end systolic volume from end diastolic volume divided by end diastolic volume. You will get your ejection fraction over there. So this is the normal value for the left ventricular end diastolic volume. Today I'm focusing, if you notice, in the linear dimension, left ventricular end diastolic diameter and left ventricular end diastolic volume. Your magic number to remember, and I don't want you to remember all those numbers today, you will keep remembering them by practice. Each time you remember one number, so a 74 mil or cc per meter square for male and 60 mil per meter square for female. So in general, if someone has left ventricular end diastolic volume for male, if you need to remember, body surface area 2 meter square, it will be 150 mil. So anything less above 150, you think, oh, this is LV is enlarged right now in male. In female, in general, 120 mil, or actually more around 110, 120, and above, you consider it to be left ventricular enlargement by volume. So we had the volume, as I mentioned. From those, you can come up with the left ventricular ejection fraction as well. So those are the volume, by the way, for normality, what's normal range and what's mildly enlarged LV by volume and what's moderately enlarged and severely enlarged. So you have parameter for linear and for volume measurement, and subsequently you get your ejection fraction for female and male. And for male, if you know, it's 52% to 72% and 54% to 74%. So there is a wide range for left ventricular ejection fraction. The prior document, actually, the normality for the lower ejection fraction was 55%. And remember those numbers just to guide you. Suppose if you measure those numbers and the ejection fraction turn out to be 51% or 50%, is it really truly abnormal? Yes, it could be a signal of abnormality if you go with absolute numbers. But more importantly, I would say, focus on the trend or the change and the clinical context through which you are reading those, the imaging of the echocardiography. So again, this slide emphasized the important prior one of Simpson biplane disc summation method is a standard method to measure it. This slide is saying the ejection fraction is not significantly related to gender, age, or body size as measured by body surface area. If you notice, we didn't specify to the body surface area, we said just absolute numbers for the ejection fraction. So here's another question right now. You can vote while I'm asking the question on the chat. So what is the difference? Left ventricular ejection fraction and left ventricular contractility, are they equal term or not? Are they equivalent terms or not? You can write true or false if you can have time right now within a few seconds, or you can answer even in your mind right now and say true or false. So the answer is false. Left ventricular contractility is intrinsic function of the left ventricular muscle wall, although on the other hand, left ventricular ejection fraction is a function of the contractility preload and afterload. In another way, if you have normal contractility and you have someone with high blood pressure, their blood pressure was normal today, 130, 140, and the next day their blood pressure is 220, and then you measure the ejection fraction, the ejection fraction might be lower. So always I say, when you read the echo, hemodynamic parameters, what's the heart rate, what's the blood pressure, how is the preload and the afterload is important when you read an echocardiogram. So it's different. So ejection fraction represents the three of them together. So now we have objective measurement for the ejection fraction. You ask ourselves, what about subjective? I use like visual estimation of the ejection fraction. It has some downside to it. Number one, first they say image quality, extreme of heart rate. If the heart rate is too slow or the heart rate is too high, different from when the heart rate is 70 or 60 beats per minute. Experience too of the person who's reading. The more you read, my advice to anyone who starts learning echocardiography, try to use it. It is not wrong because common in clinical practice to use visual estimation, and then go do biplane disc summation method and see how close you are. Sometimes your eye is more accurate. If you don't have a clear endocardial border, you have to use visual ejection fraction assessment. And the problem with this one visual estimation, you have one plane at each time, and sometimes when you look on 2Ds or foreshortened image, the ejection fraction looks much better. Then you look on a different view, it looks like different number, and you get lost. You're like, well, how can I call it? You try to come something in between, but use it. Again, the most important is the objective assessment of left ventricular ejection fraction. Again, eyeballing is subjective, experience dependent, large inter and intra-observer variability, and lack of standardization. Because I don't know if you think you are experienced, maybe you are wrong, because to whom, how would I believe you have the experience? So anyhow, keep it, but it has its own downside, and always support your finding with objective measurement. Again, we mentioned it, modified Simpson biplane disc summation method. Even if you are the same person reading echo today, and a week later you look at the same echo, you might give it 55, you see it again, you say 60%. Although it's the same echo, you are the same person. And here is again, when you measure left ventricular, it defines the endocardial border. If you notice over here, both lines, they might look, it looks right for you, but in reality, the yellow one is incorrect, because what defines the endocardial border for the ejection fraction is the junction between the compacted myocardium and non-compacted myocardium. The white one is the correct line because you are including now the border of non-compacted myocardium. It's a contractility, it's a function of the compacted myocardium, not the trabeculation. Do not include the papillary muscle and don't include the mitral valve leaflet. It should be inside the cavity, not part of the LV wall. You start at the level of the mitral annulus, again tracking the compacted to non-compacted myocardium all the way to the cardiac apex. Do not include the papillary muscle or the mitral valve leaflet. The moment you end at the other end of the mitral valve annulus, automatically the machine will calculate the volume for you, and you apply the same thing in apical 4, apical 2s, in diastole and systole, and subsequently you get your volumes as well as the ejection fraction. There is something when people do like apical 4 chambers view compared to 2-chamber view. Look at the length of the LV. The normal LV geometry is a bullet shape. رصاصة مثل الرصاصة. فبullet shape, you can see the apex, if you see it here, more spherical like this one, and if it's more spherical, it will be contracting in. You suspect you are foreshortening the LV. It will overestimate the ejection fraction. It will underestimate the cavity. By visual estimation, when you look at the apex, you can overcall the ejection fraction. You can miss left ventricular apical thrombus. So it's easily. And when you look over here, you can see the coronary sinus going to the right atrium. You know that you are shortening the LV cavity. And you can compare the 2-chamber with the 4-chamber view. You can see there is difference in the length of the LV length. So you know that it's already foreshortened. More likely to foreshorten the LV cavity in 4-chamber than 2-chamber view. So this is very important actually. And if it's foreshortened, you can see it over here. This is right view over here. And you can see it's more spherical apex, different from this one. The LV cavity is more lengthened. All what I'm asking, please remember it, and you will be correct all the time, hopefully. You just bring your probe down and more lateral, and you get better views. So if you get lost, you are not sure, you are just starting learning, just bring the probe down and more lateral. So this is if you don't see the endocardial border using contrast. Contrast you can see, can define and can visualize the endocardial border really well. 2-chamber view, 4-chamber view, you can see it looks very nice. You have no doubt where is the line, where I'm going to track. It's very clearly visualized. When you don't see 2 segments per the guideline, 2 adjacent myocardial segment not visualize it, then you can use the contrast. So there is another question over here, true or false, please answer in your mind or in the chatting box. The angle between your image 4-chamber view different from 2-chamber view, to move the 2-chamber view is a 90-degree angle, which actually in reality, it is not true. As we see right now over here, you can mention the 2-chamber view, 4-chamber view, and long axis view. So if you notice 4-chamber view over here, this is the way it cut the LV cavity. It can see the anterolateral wall, the inferoseptal wall. This is the RV over here. This is the LV. And you see the anterolateral inferoseptal wall, and that's exactly the myocardium segment you see in apical 4-chamber view. When you move to the 2-chamber view, you can see the angle, maybe 45-degree angle, you will get 2-chamber view. So when you image patient, you twist the probe or turning the probe just 45-degree to see a 2-chamber view image. And you can see this is your anterior wall and this is your inferior wall, and subsequently you get your long axis view. And all those myocardial segment has a specific name. Try to use them when you describe wall motion abnormalities. And the wall motion abnormality scoring system score, for example, you have 16 myocardial segments, 16 of them. So you'll have 1 for normal, hypo 2, akinetic 3, dyskinetic or aneurysmal will be 4. So for wall motion scoring. And this is the myocardial segments. If you can go through them, you can read the document. We can give you a copy. You have either 16 segment model, 17 segment model, or 18 segment model. And this is the myocardial supply for those myocardial segments. This is the LED distribution in green. Left anterior descending coronary artery can supply up to the apical inferior. Mid inferior septum, either LED or RCA, coronary artery. And this is the anterolateral wall, either left anterior descending or left circumflex, for example, obtuse marginal branch. And the basal inferior segment and the mid inferior right coronary or circuit, depend which is the dominant artery. So this is the segment model. I use the segment model for wall motion abnormalities, 16 segment model, from basal and basal anterior, mid anterior septum, basal anterior septum, and basal inferior septum, basal inferior, basal inferolateral, and basal anterolateral, and so on. It's counterclockwise. You go and you start with the anterior segment and you go through all the myocardial segment when you describe the wall motion abnormalities. The 17 segment model, usually we use it when we talk about myocardial perfusions. And that's again saying the same what I said so far, 16 segment model or 17 segment model. Subsequently, we talked about the LV so far. Let us move on and talk about the second chamber, the left atrial. The left atrium. So left atrial, the question comes, left atrium is gender dependent. The answer is false, okay? So we can move to show you a very important slide. This is slide reflection, the left atrium. The left atrium, always I say it, if you need to look at the health of someone who doesn't have medical conditions, maybe some high blood pressure, maybe not, if you image the heart, I will pick up one chamber, assume you don't have congenital heart disease or any other abnormalities, I say pick up a chamber, look at their left atrium. And the left atrium size itself, it tells you a lot about the health of that person. It's a thin wall. Once the heart subjective to chronic loading stress, the left atrium will be enlarged, and either enlarged with normal pressure at this slide over here, or enlarged with high pressure. And sometimes will be normal size with normal pressure, or normal size and high pressure. I should add another balloon over here with normal size and high pressure. If you have an acute condition, the first time event, the left atrium will be high before, for example, a newly diagnosed acute heart failure or acute MAR wasn't just papillary muscle rupture, the left atrium may be normal and the pressure will be significantly high. So it's like the hemoglobin A1C of your heart. For endocrinologists, use hemoglobin A1C. For us, we can use the left atrial size and the pressure, especially the size. If enlarged, it tells this patient exposed to a lot of stress. And there is multiple studies. I deleted them actually from the presentation today to make it simple and straightforward. Showed us the studies in people who have diabetes, people with some high blood pressure, even a study in normal population screening them. High left atrial volume predict worse outcome. Very important to see to focus on the left atrial volume. So the measurement, linear measurement that we use to measure the left atrium, not recommended. We are not going to use them. I don't use them personally too. I use the left atrial volume. Apical 4-chamber view, apical 2-chamber view. Track the left atrium, the endocardial border in the left atrium. Do not include the pulmonary vein entrance, for example. Do not include the left atrial appendage, and do not include the space below the mitral valve. So you stop at the level of the mitral valve annulus. If you look at this slide, you start tracing over here. Do not include the pulmonary veins again. Do not include the left atrial appendage again. It's just the left atrium over here, and you stop at the left atrial annulus, mitral valve annulus, and you will get your volume. When you measure it at the end of systole, not the systole of the left atrium, the LV systole. When we say systole and diastole, we mean the left LV systole and diastole, ventricular systole, not atrial systole. So you will have one dimension right now, just at the end of systole. Why that at that point? Because at end of left ventricular systole, this is the highest size of the left atrium, and used by plain disc summation method. You don't need to know, again, the same principle that we said earlier, multiple small discs, and the summation of those can give you the left atrial size. And this is the recommended method. And this one, some people, when they image apical 4 or apical 2, remember our focus is the left atrium. Sometimes the LV is completely open up.
Mansour, mute. Enter mute. We can't hear you. Can you unmute yourself?
Do you hear me now?
Yes, thank you.
Yes, let me go back to the other slide again to say it again. So the left atrial dimension, the longitudinal dimension is different from the LV dimension. Remember, our focus is the left atrium now, is not the LV. I know our focus always when you do echo is the left ventricle, but take it one chamber at a time. I need to see left atrial volume. You have to change, even if you foreshorten the LV, doesn't matter. Open up the left atrium, and again, it's at the end of systole, you make the measurement, and we mentioned which structure you should not include in the measurement. And those are the normal values. In the prior documentation, use 28, not anymore. So the normal values right now, 16 to 34. And again, I said 10 times, all the numbers that you have alive is just numbers. Suppose if you see it 33, could it be abnormal? Yes, it depends on the trend. If I have prior echo showed it maybe 20 and now 33, it's a change. It's like dropping the hemoglobin. The normal is 6, for example, 12 or 12 and a half or 13. If someone was 17 and now 14, it's a drop. They might be bleeding right now. So trend is important in all the numbers in medicine. Trend is very important. And this is what determines the severity of left atrial enlargement. Above 48 is severely enlarged. Bare body surface area, remember, okay? Not the whole volume here. So some people, you have 90, then you divide body surface area severe. So this is the relationship, and there is a studies I took them out. So hopefully maybe we'll address them in the future and have another talk. Left ventricular mass is measuring the mass of the LV, and it's a complicated equation. To be honest with you, you don't need to remember it. All what you need to measure, as you see in the equation, left interventricular septal thickness, LV in diastolic diameter, posterior wall thickness, and subsequently you get your LV mass. LV mass means how much your heart can weigh. If I throw the left ventricle, take the LV, cut the LV out of your heart, and then throw it in a scale, how much is it going to weigh? The magic number to remember, 95 gram per body meter square, and 115 for male. Anything above, you have high LV mass. And remember, there is a difference. Let me see it here. So if the LV mass, the muscle high athlete, and it's good, but high LV mass in patient with high blood pressure, it's bad prognostic sign. It's not good. It's not like when you build up your muscles, you're exercising. This is different. That's not good thing. So this is a question, and I need everyone to think about it before I go give you the answer. To have left ventricular hypertrophy and echocardiogram, the LV wall thickness should be more than 1 centimeter. So when we mentioned the linear measurement earlier, I told you about left ventricular end diastolic diameter, magic number 58 and 52 for female and 58 for male. The thickness of the wall, 1 centimeter for male and 0.9 for female. So this is wall thickness. Sometimes it's tricky when you document an echo. You say like increase in wall thickness. I don't know if it's hypertrophy or not, maybe something else, maybe amyloid heart disease. But at the same time, when you document the LV wall hypertrophy or LV mass, you don't have to have thickness to have LV mass. Because remember, as the left atrium can enlarge, the LV can enlarge, become a globular heart. And I can show you in the slide. Look at this slide here. The LV wall thickness here, it's normal, but the size of the heart is high. And remember, if I take the LV and throw it in a scale, the weight will be higher. So you have high mass. We call it eccentric hypertrophy. It doesn't have, so it's hypertrophy, but the LV wall thickness is still not high. So the size matter of the heart, if it's enlarged or not. And this is what we call it concentric hypertrophy and concentric high mass. But what does it mean concentric? And this comes in board exam, whoever goes in echo board exam. So we measure the mass, we have how much mass, and then measure relative wall thickness, which is the posterior wall thickness relative to the LV cavity. It's more than 0.42, it's concentric hypertrophy. So let me move to the other slide. Hopefully I will try to make it simple. Concentric means the wall thickness is high, the mass is high in another way, but the cavity is small relative to the wall. So the relationship between the cavity size to the wall, and this one eccentric means dilatation of the LV. It's high mass, but the wall still, it's okay, but the diameter, look, it's high. So if you say relative wall thickness, the wall thickness relative to the cavity, it will be less than 0.42. So remember those numbers, at least remember this last paragraph, because it's important. Someone has AI, they will have eccentric hypertrophy. Someone has AS, aortic valve stenosis, they will have concentric hypertrophy. Hypertensive heart disease will be in this category as well. So now we are going to measure the other chamber, I call it the aortic root measurement, the aortic annulus. So we had multiple measurement, annulus, sinus of valsalva, sinotubular junction, and ascending aorta, the proximal ascending aorta. The measurement, you should make it in left parasternal long axis view. And again, if you need to measure it, you have to open up the aorta. And sometimes the alignment of the tubular aorta, at least over here, is different from the LV alignment. Remember, each chamber is different. This is the long axis of the aorta. You don't have to open up the LV. Again, your focus is the aorta. You can foreshorten the LV when you measure. And sometimes to measure the ascending aorta, you have to go more medial and one space above, closer to the sternum. So higher and more medium to open up the tubular aorta. Which measurement in those four, answer in your mind right now, if you are making measurement, 1 or 2 or 3 or 4, which one do you think is wrong measurement if you measure it? So number 1 is the wrong one, and I will tell you why shortly. So number 1 again is wrong. 2 and 3 and 4 are correct. So what is the definition of aortic annulus? The aortic annulus, true or false statement, is a distinct anatomic structure where the needles of the 3 aortic leaflet meet. So the answer is false. It is not distinctive structure. It's not distinct. The aortic annulus is just imaginary line, and that imaginary line, it connects the needles of the aortic valve leaflet over here, the sinus of Valsalva. If you see the green dots over here, it's just imaginary line. It's over this area over here. This is the aortic valve annulus that we measure it. And it's important to measure. When people put TAVR, they will say like, what's the measurement of the aortic valve annulus? And let us see here. And this is the measurement. You measure it in mid-systole. The initial slide I showed it to you, when you measure the annulus, the aortic valve leaflet were closed. So it has to be open up. If you, in the exam comes, should leave it closed or open up, it has to be in mid-systole, because in mid-systole, the annulus will be more rounded as the blood comes out of the heart and give you a true, right, correct measurement of the annulus. So again, in mid-systole, it's not different from the other. At sinus of Valsalva, at sinotubular junction, proximal ascending aorta, the measurement will be made at the end of diastole, And one thing more, I have to remind you, when we measure the measurement here, you measure it leading edge to leading edge. What does it mean? Leading is the front one. So you start not from the inner edge over here. You start from here to the front side over here. For the sinotubular junction, you start from here above, not from inside, from there to the front wall over here. Leading edge to leading edge, that was done. This is the way it was done in studies before, and it will be the same way that we measure it right now. Because if you can change, you can change by up to 1 to 2 millimeters sometimes different. Okay, and this is the slide over here. It showed you what's the normality. Remember, different normal ranges between young 20 to 39 and above 40-year-olds. So each one of them has different numbers, okay? Just important to remember, and bare body surface area. So as the body surface area higher, you will get higher numbers at sinus of Valsalva here, the measurement that I'm talking about. And this is the normality range. You need to remember them. At least remember, imagine some of them. Imagine proximal ascending aorta, common in clinical practice. The upper range is 3.0 plus minus 0.4. So if someone body surface area is 2 meters square, the upper limit of normal will be 3.8. So at least remember, proximal ascending aorta will be around 3.8. If you go to sinus of Valsalva, the upper limit of normal, 3.4 plus minus 0.3, so it's around 4.0. If you multiply this by 2, it will be 4.0 for body surface area of 2. But remember, height is not just, so what affect those numbers in the aortic root, it is not just the body surface area, height and age, as I mentioned earlier. So take every case individual case. And this is from Brunwell. It can give you an approximate number of 36 for ascending aorta, 3.6 centimeter, sinus of Valsalva up to 45 millimeters, and aortic valve annulus. So at least remember those measurements. And this slide saying hypertensive heart hypertension can affect the aortic root, but it doesn't affect deep in the annulus. So it affects mainly the ascending aorta, but the root measurement stay okay with hypertensive disease. Age-related dilatation of the aortic root is the most common cause of AI in developed countries. So it is common scenario that we see it. Now we are moving to the RV and the right atrium. As you see over here, here is the RV. It's encased the LV cavity over here. It comes in front of that, and the shape of it and the geometry, it makes it difficult to measure the RV. As you notice over here, if you open the RV, there is inflow, the main RV over here, and the outflow of the RV. So if you have a specific number to measure the RV, it's different from the LV. LV made our life easier. RV is hard. And sometimes we depend on visual estimation as well too. So this is a true or false statement. In normal individual with normal cardiac structure and function, the left ventricular end diastolic volume is larger than the right ventricular end diastolic volume. Is that true statement or not? That's a false statement. We think sometimes the LV is the main and the LV maybe has larger volume. If I ask you, how is the cardiac output? Please answer this one in your mind and see if you're going to answer correctly or not. The cardiac output of the LV compared to the RV, are they the same? Yes, the same. They are not different. So if they are the same, but the RV in general, the ejection fraction is lower than the LV for normality, you ask yourself, if the ejection fraction is lower, so how much the squeeze is lower? It must have higher volume in diastolic volume, because how is the heart rate of the RV different from the LV? Both of them, they have the same heart rate. You cannot separate the LV and RV. You cannot ever say, for example, I have the heart rate for the LV 60 and the RV 70. It's just one electrical system. You will have one heart rate. You cannot separate them. You can separate the atria from the LV. You have like AV dissociation, but you cannot have RV, LV dissociation. So if the heart rate is the same, the ejection fraction of the RV lower, and the cardiac output is sequence of the ejection fraction by heart rate, then the volume of the RV in general higher. of the LV. This is the views that we obtain the RV measurement. Remember, when you do apical 4-chamber view, the LV apex will be in the center of the view, and you can see the RV encasing it, and look at the RV apex where it is, and look at the focused RV view. What you bring your probe, I told you before, you never get wrong, bring lower and lateral, and you can displace. You see, as you go more lateral, you visualize more of the LV, but look at the RV comes closer to the center of the screen now. And instead of more lateral, it comes in. So you focus on the RV and it will open up the RV, and the dimension of the RV will be higher. If you measure it over here, you can underestimate the RV. This is RV modified apical. This is you go more medial. So as you go more medial with the RV is close to the sternum, you will open up more of the RV cavity. And this is the measurement you can need to measure. So the measurement in RV focused view, the one in the middle, you have to go more lateral, and you see you can bring the RV base in the view in the center of the screen over here. And the magic number for today to remember, at the basal part to measure below the mitral tricuspid valve annulus, the measurement is like 41. Anything above 41 millimeter, it's high. So you measure it again at the end of diastole, closer to the annulus in the lower 1/3. And anything above 41 millimeter, it's high abnormal. This one to remember, in the mid RV cavity between the apex and the basal area, midway, you measure it. In the RV focus view at the end of the diastole again, it will be 35. So take out 6. So 41 minus 6, 35 to remember. So, and again, in left parasternal axis view at the end of diastole, you can measure from RV free wall to the junction between the septum and the aortic root, and the measurement is 29 upper limit. So again, 41 minus 6, 35 minus 6, 29. So if you remember those three numbers, I think more than sufficient. We are not going to mention the numbers below. So if you remember one number and you say like, I don't have hard disk for it, and my brain cannot accommodate this number, remember number 41. So let us show you, we move to the next slide. RV wall thickness, subcostal view, end of diastole. And when you see the tricuspid valve, leave it open, the anterior tricuspid valve, leave it open, at around in the middle 1/3 of the RV free wall, anything above 5 millimeters is abnormal. The standard deviation 3 plus minus 1 up to 5 is normal. Above 5 millimeters abnormal. Do not include epicardial fat, okay? Just from the endocardium to the pericardial wall over here, anything above 5 is abnormal. And now we are going to have something more objective to finding to assess the right ventricular function. Remember, when the RV contracts, if you notice in the echo, it contracts more in the longitudinal axis, meaning it is not circumferential contraction mainly, it's more longitudinal. So up and down, the LBU, like bouncing up and down, you have in the apical 4-chamber view, place the cursor at the lateral tricuspid valve annulus using the M mode over here, and you try to be aligned because it can underestimate the velocity if you come from this angle. So you have to be parallel to the RV free wall, and you measure it. Anything less than 17 millimeters abnormal. And how would you measure? By the time you place the M mode, it will track the movement of the lateral tricuspid valve annulus. We call it TAPSI, tricuspid annular longitudinal. Again, longitudinal excursion by the M mode. And the difference between diastole and systole, the vertical line over here. And if you do it once, believe me, it'll be like a piece of cake for you. Anything less than 17 millimeter indicative of abnormal RV systolic function. And again, because mainly it's longitudinal function, it's just one point only in the RV, but it's reflective of the RV function. The other one, you do tissue Doppler, pulsed tissue Doppler, S-wave, systolic velocity of the RV exactly at the same point like the M mode over here. You try to be as parallel as possible to the RV free wall, and anything, the machine will calculate the systolic velocity at the peak, and then you measure it. Just you put the marker, and the machine will tell you exactly anything less than 9.5 centimeters per second, it's abnormal. So magic number 17 and 9.5. You don't need to remember TAPSI today. Don't remember this number. Remember TAPSI less than 17. Don't have to worry how to measurement, because you will have a workshop, hopefully a hand-on experience. They will tell you how to measure, but at least know the rationale, where and when and how, in systole, diastole, which view you should measure it, and each time you will remember one parameter. We are not going to go to the strain, okay? We are not, hopefully another session. RV area, again, an RV focus view. I told you where is RV focus view, end of diastolic area, end of systolic area. As simple as it is, as the name implies, you just track the endocardial border. Don't include the trabeculation, don't include a moderator band, don't include muscles, valve muscles, don't include the leaflet itself. So all of those should be inside the cavity. And then if you track it in systole, in diastole, and make the difference, we call it fractional area change, like the ejection fraction of the LV. Less than 35 is abnormal. Don't remember this one. Remember TAMSI today, remember basic diameter 41. But you know at least it does exist. This is the RV volume. If you notice, the RV is a complicated structure over here. This is a three-dimensional volume of the RV. This is toward the RV outflow, RV inflow, and the main RV over here, interventricular septum over this area. And you see how complicated the ejection fraction you see for abnormal is than 45, different from the LV, because the volume in general you see over here for male 87, different from other one we said 74. So volume RV surprisingly is bigger than the LV. So, and I showed you the last one just to show it to you how it looks like on the 3D image. So right atrial size, how to measure it, apical 4-chamber view for the right atrium. We are sorry, we don't have enough information yet. We don't have two-dimensional like 2-chamber and 4-chamber. We have only 4 chambers, and you can measure the volume. We call it single plane disc summation method, this one for the volume, and that's what I use. And this is the normal range. I don't want you to remember today. At least you know the measurement, apical 4-chamber view. You track the borders over here as shown on the screen over here. Don't include any, like for example, right atrial appendage if it was seen. But this is the volume. There is an area measurement. Area, just track the endocardial border of the right atrium. It will give you the area. And in the document, I'm going to send you a summary of that document, actually multiple pages. You can go through them and each time try to remember one number. IVC measurement. So this is the inferior vena cava over here. And you can see the measurement. You measure it 1 to 2 centimeters from the junction of the right atrium and the inferior vena cava over here. And what is the normality for the measurement? Again, don't measure it over here like 2 inches all the way, because this is, you are measuring IVC only, away from the heart. You have to be closer to the heart, because if you notice, the measurements are different. And here is the normal number. So I think it's important to remember those numbers. You have no choice, sorry about that. Anything less than 2.1 and the collapsibility more than 50%, here is your right atrial pressure, 0 to 5. More than 2.1 and collapsibility less than 50%, 10 to 20. And we use the number 15. For the simplicity, why? Because you need to come up with a number for RV systolic pressure, and hopefully in the future you can know hemodynamics of the heart and how to measure estimated pulmonary artery systolic pressure. So that's why we have to one number only. So anything less than 2.1 and collapsing more than 50%, low pressure. If it's high and collapsing less, so pressure is high. Anything in between, for example, less than 2.1 and collapsing less than 50%. So here is your number. It should be, as you expect, 8, something in between. So 8, it depends, anything that other than the above numbers, it will be 8 right atrial pressure. And it's important, okay? As you know, in a mechanically ventilated person, it is not accurate to assess the RA pressure from the IVC. So I will stop right there, and hopefully we finish on time. And we can answer questions, and hopefully if anyone from the expert panel have any addition, it will be great to listen to all of you.
Excellent presentation, Mansour. Mashallah, and a great presentation. I think you covered everything with chamber quantification in details, very simplified. So wonderful, excellent. I'm gonna touch base on different aspects in your presentation, but first I would like to ask our expert panel if they have any comment. I'll start with Lubna. Lubna, if you have any specific comment on Dr. Mansour's presentation, you can.
Assalamu alaikum.
Wa alaikum assalam.
Assalamu alaikum. Very good presentation, Dr. Mansour. Very excellent, actually. I'm just going to add a few points from a sonographer point of view regarding how to achieve an accurate measurement for the LV function, or what we call Simpson. As we all know, that definitely is not available in Libya. So here's a few points. Number 1, decrease your depth and your width for that 4-chamber to get that LV on axis. If whatever machine are you using, A95 or Siemens or Philips, there is a frame rate and there's compression. What you need to do is increase your compression, decrease your frame rate. Now, there's no magic number. It's all visual. You look at your image, and once you see the myocardium very clear, you need to stop there. Also remember the focus point there. Now, I try to reduce my frequency with my compression, and the image did not look really good, to be honest with you. So if you increase your compression, try not to touch the frequency. If the increasing compression and decreasing frame rate did not work, then move to step 2, which is decrease frequency all the way down, and hopefully you'll see the myocardium very clear. I've been actually using these 3 techniques lately, and it's actually, I haven't been using Definity a lot because of these 3 things that I play with in a machine. Now, sometimes what I need to do, increase my gain, 2D gain, it helps a lot. Go ahead and increase your 2D gain. There's nothing wrong looking at the function to decrease your 2D gain. I know the doctors don't like it, but if there's a point, then go ahead and do it. Other than that, yep. I mean, that's all what I have. Yep.
Thank you.
Thank you.
Thank you, Lubna. As usual, very valid and technical point. Thank you so much. Osama, do you have anything to add the Mansour presentation?
Assalamu alaikum. Barakallahu feek, Dr. Mansour. Very, very, very great talk. I've learned from it myself, even though I've been reading echoes for a few years now. These are just some general things that I was just writing while you were talking. And I'll start even before the scan. And that is, you've all heard how many times Mansour was talking about indexed. And so every patient that walks into an echo room has to have a height and weight for you to be able to measure any structure of the heart indexed to the body surface area. And it's a very simple equation. The square root of the height times the weight times 3,600. That's the easy one to remember. So always measure the patient's height and weight, because you will not be able to, for example, assess the patient's diastolic function if you don't have the left atrial volume indexed. So start by measuring the patient's height and weight. Now, the other, just some simple points in terms of measuring the LV wall thickness. As Mansour mentioned, when you have a sigmoid septum, you should not include that as being the wall thickness of the anterior septum. So you have to go down a little bit towards the apex. But we will see sometimes that there is a cord that is just underneath the anterior septum. And that is not part of the septum. So if you see that, try to move your image back and forth until you know that where that cord is, and exclude that from your measurement. The other point is, don't forget that the RV septum is part of the LV septum. And so sometimes the moderator band will actually be very close to the, all the way up to the, almost the aortic root, you will see. So be careful not to include that in the measurement as well, because I see that a lot with sonographers, but not Lubna, of course, that they overestimate the wall thickness, and almost everybody ends up having left ventricular hypertrophy. The other thing is the size of the LV. So even though we know we're measuring how to measure the LV size, but it's only one measurement of the base of the left ventricle. And sometimes if you have an aneurysm in the infralateral wall, you're going to overestimate the LV size. So keep that in mind when you're measuring the LV size as well. Measuring the left atrium. So the atrium, you should enlarge in four different planes. But unfortunately, it can be restricted by your sternum and your spine. And so sometimes you get an elongated left atrium. When you have an elongated left atrium, and if you just measure the 2D measurement, it might be normal. And that's why left atrial volume index is very important, so that you don't miss an enlarged left atrium. Going to the aorta, so the structures of the aorta, as Mansour said, they are indexed. Now, the problem is there's really no consensus on what to do with the indexed aortic structures, because for clinical purposes, we still use 5.5 centimeters in order to operate and replace the root in the general population. I'm not talking about the other subclinical issues, but in general, it's when it's greater than 5.5 centimeters, that's when you send the patient to surgery in general. So even though you might measure the index, let's say it's a 200 kilogram patient, if you measure the indexed aorta, it's going to be less than 5.5. Sorry, the index is going to be less than, I think, 1.9 for men. You would not say that I'm not going to send this patient for consideration for surgery. So even though we do measure the indexed aorta, it's not always clinically applicable. The other thing is the measurements. Why is it that the measurements are from leading edge to leading edge? The problem is the initial studies were done that way, and I don't personally know why. So you just have to measure them, and that's the way they were done in the studies, and that's the normal values that we have. The only exception is the descending aorta. So the descending aorta is actually measured inner edge from inner edge to inner edge. And the other exception is well, I guess not exception from the aorta, but the IVC is inner edge to inner edge as well. And like Mansour said, 1 to 2 centimeters from the junction of the right atrium. And like Lubna said, always try and bring the focal zone to the area you are assessing so that you can get the best picture possible. And the measurements, when you're tracing things, it's always, you're tracing the black-white interface or the blood tissue interface. I think those are the main things that I wanted to add. Thank you.
Yeah, thank you, Sam. I think these are a very good point. I see Dr. Hanan Nagrahi joining us. I'll get back to you, Hanan, if you want. But since I have you, Osama, I think you brought a very good point. Mansour, I wonder if you can pull up the image on that ascending aorta, the measurement. So at least show us what Osama meant by leading edge to leading edge versus inner edge to inner edge, because that's very, very practical point. And I think Lubna also pointed out, when you increase your gain in those situations, you can easily measure, have an accurate measure. Always doing it in a zoom view, it decreases your margin of error. So yeah, so if you can see here, that's the LVOT, right? This is the LVOT. He's talking about the leading edge to leading edge, inner edge to inner edge. But for the ascending aorta, it's a leading edge because of this study they were done. Osama, since I have you, I'm going to ask you a question that Mansour talked about regarding what's the difference, okay, between the LV wall thickness and the LV mass. I'm just starting echo, just learning, and I'm a little bit confused. You mean that the thickness is different than the mass? I wonder if you can explain that to us, and then I'll have Mansour comment on that too.
So Mansour touched on it, the LV wall thickness and the LV mass. So before I start, clinically speaking, there's not much clinical application that I see that's going to change your management. For example, if you see somebody who has hypertension and, let's say, concentric hypertrophy, you're going to treat them for that hypertension the same way as you're going to treat somebody who has hypertension and has normal geometry. But for research purposes, maybe, or for just academic purposes.
An outcome.
Yeah. So for research purposes and outcome, then you should measure the mass rather than just the thickness. And the mass has its own equation. Unfortunately, it is limited because it only assesses the posterior wall. So it doesn't assess the whole, all the walls of the left ventricle. So when you have, for example, concentric hypertrophy, the outcomes are somewhat worse than somebody who has hypertension and has normal geometry. Similarly, if they have dilated, if they have, let's say, eccentric hypertrophy, the left ventricle is dilated, but the walls are not thickened, then the outcome is also worse than somebody who has normal geometry. So it's more for research and maybe clinical outcomes, but the management usually is essentially almost the same.
And Usama, you can say in the LV mass, اللي هو high LV mass is a more reliable reflector for hypertensive heart disease, more just using the LV wall thickness. I think the data showed in the patient with the high LV mass, they have worse outcome in terms of cardiovascular disease. دكاتره الحضور معنا حنعلقوا على نقاط معينات منهم على ejection fraction والRV wall thickness والال في او تي ميجرمنت نقطه مهمه جدا بالذات لما يكون عندك ستينوسز. لكن لو في اي حد فيكم عنده السؤال يا ريت يريز هاند باش نعطوه المايك يتكلم او يحطه في الشات بوكس في دكتور يوسف الضرات. تفضل يا يوسف.
السلام عليكم.
وعليكم السلام ورحمة الله.
Mansour, great presentation. بارك الله فيك. شكرا. يعني very well summarized بالنسبة للchambers. إن شاء الله we look forward to more presentations from you. لو عندي سؤال as an electrophysiologist I always look at the left atrium. فكان الانترست بتاعي على left atrium index. Left atrium volume index. You mentioned two papers or two studies. Feel more than 40. More than 48. 48 seems like in 2015, like a more recent study. Which is more verified? You recommend using the volume index more than 48, like the difference seems to be big between 40 and 48. So if you can comment on that, the volume index for the left atrium. Shukran.
Excellent question. تفضل Mansour. Before okay, go ahead.
So if I understood the question well from Yusuf, is mainly which method is recommended? We have the linear measurement, and I think Osama mentioned that sometimes you have elongated left atrium, so the left atrium AP diameter will be not significantly different, but if you go to the longitudinal diameter, it will be significantly high, and that's why from 2015 document, the recommendation from chamber quantification to use left atrial volume index. And there is a range, so you have to, I would say, like from 41 to 48, for example, is moderate, and from 34 to 41 is mild, and so on. I know the papers that higher left atrial volume index is predictive of worse cardiovascular outcome. But there is a difference between someone who's 45 and 50. I don't know if there is papers looked at exactly, although we know if they classify severity mild and moderate and severe, something that's labeled severe, probably it will be associated with worse outcome. But personally, I don't look up those papers that show the difference between moderate left atrial enlargement versus severe left atrial enlargement.
Thank you, Mansour. على فكرة أسامة يا يوسف, sorry, your question. In general, the most accurate way of measuring the left atrial size is the volumetric volume index. You measure it in the 2 and 4 chamber view with the length, and you index it by surface area. To your point, as an electrophysiologist, there's a strong data that if the left atrial volume index more than 34, 34, increase the risk of stroke, AFib for you, and also heart failure. El 48 this is severe. So patient with a large left atrium, even if it's more than 34 by volume index, that they have worse outcomes in terms of future event of stroke, atrial fibrillation, and heart failure. But when you talk about 48, the number you mentioned, this is severe. From your perspective, you don't, I won't think you would be excited doing an ablation for patient with severely enlarged left atrium more than 48, right? Because it's all fibrosis. And if that answer your question, Yusuf. Yusuf, if you have, لو عندك تعليق قد نمشي لنقاط معينة تانية.
تمام, بارك الله فيك. I mean, I agree with you. Severely dilated, definitely it's something we don't like seeing. And though recently there's data in a long-standing persistent AFib and severely dilated left atrium, there's a conversion procedure, hybrid procedure, has shown good outcomes. I mean, based on that study, 1-year outcomes. But the main point was just knowing the volume index, because I've seen both studies. So basically, the 2015 one is based on different measurements, on different volumetric measurements. Is that right?
Yes, and actually,
Yeah.
the 2015, actually in the past, the left exercise more than 30 was enlarged, so they moved to 34 because of the data.
Yeah.
Like what Mansour, I think, mentioned, more data, that's why they updated the guidelines. Thank you. I have a question about the ejection fraction, and I would like to hear that from Dr. Hanan Megarhi. Measurement, we know a lot of cardiologists, they still use M mode, okay, to measure ejection fraction. As you know, and in the guidelines, recommend to use the Simpson method, which is like more objective, which is a biplane, right? M mode is only one plane to measure 3D structure, the heart. The guidelines recommend to use the biplane, the Simpson method that Mansour explained in his presentation to measure it. And actually, the accurate data is for the 3D ejection fraction, and the newer machines is kind of more updated. And I think in the future it will be very easy to measure the ejection fraction via 3D model with the newer machine. I think Philips, they have the heart model, very easy to use with just kind of a few films. So what's your take, Dr. Hanan, على measuring the M mode with limitation for the patient when you talking about ejection fraction?
Yeah, mostly as you said, Dr. أولاً السلام عليكم. Sorry because of سبب تأخيري دكتور أيمن. بالنسبة about the ejection fraction measurement recently, we have changed from طبعا من ال M mode. We use now the Simpson, the volume assessment of ejection fraction, which is more accurate. Regarding the M mode, as you know, there is a different way, depending a lot and giving us sometimes wrong assessments for the ejection fraction, especially in the ischemic heart cases. So the more accurate now, and most of us now working with the Simpson side.
Yeah, exactly. Like what you said, بالذات في المرضى اللي عندهم ischemic cardiomyopathy، مثلا يبدا المريض عندك apical akinesis anterior STEMI، مرات البيزل ستيل نورمال، تعطيك نورمال ايجكشن فراكشن هو مش اكيد. خلينا نسال لبنى بالنسبه ليك يعني do you use the M mode for ejection fraction? What's your take على ال visual estimation of ejection fraction? We know it's per experience dependent, وفي there's observer variability up to 10% for ejection fraction. Do you use وال 3D لبنى تعلقين على النقطه هذه بالنسبه للام مود والايجكشن فراكشن بصفه عامه، بعدين ناخذ راي دكتور اسامه ودكتور منصور. شكرا.
لا والله we don't use the M mode actually for evaluating the LV function. We do use Simpson method, and I use volume, the 3D volume for the ejection fraction. That's pretty much what we do.
بالنسبة للسيمسون when you obtain your measurement you zoom on the LV صح؟ LV zone view.
Yeah, you need to reduce your depth, and well, it's an actually zoom. I actually reduce I found this I don't know, it brings me my myocardium better. I reduce my depth, decrease my width. I do not zoom in this case. I zoom in the valves. I do not zoom in the LV function.
And that will increase your frame, right?
Exactly. Yeah, increase your frame, reduce your compression, increase your 2D gain a little bit, all that stuff, and then hopefully you'll get a good image to evaluate your LV function by Simpson.
What's important, I think, point Lubna, I think I'm familiar with, انك انت pay attention to LV apex. If you see it like more rounded, globular, you're foreshortening. You have to see it like more kind of triangle ولا bullet زي ما قال منصور. منصور شو تعليق على النقطة هذه بالنسبة للإيجكشن فراكشن الديفرنت ميثود؟ قلنا عندنا الام مود اللي هو one plane to measure 3D structural heart versus the visually estimated ejection fraction مع الباي بلين والسيمسون. شو تعليق على النقطة هذه وبعدين ناخذ بعدها أسامة.
Yes, certainly I'm for biplane disc summation method because it tracks two-dimensional LV and track the LV throughout the endocardium from the apex to base. And just the M mode, remember, as you mentioned earlier already, if you have someone with stress-induced cardiomyopathy, Takotsubo or LAD-MI, maybe the basal will be hypercontractile and the mid segment will be hyper. Actually, will be hyperdynamic LV by the M mode, and actually the ejection fraction is low, just compensating basal and mid ventricular hypercontractility. So it's not really reflective. To add one thing more to Simpson biplane disk summation method, I would say the machine calculate whatever you track. Remember that it is not just about the method. The machine is a machine, and the machine gives you a number at the end of the day to the point that you track. Wherever you track the endocardium, I have seen people a lot. It's not like it's not unusual. I'm trying to say they track the endocardium wrongly, and then the ejection fraction comes to me like 45%. When I look visually, I always say use your logic. All the numbers or the machine is not a replacement to your logic. So look at the image yourself with your eyes. Does look like corresponding to biplane disk summation method. It is not fault of the measurement, it's fault of the way that you made the measurement. So just keep that in your mind. Sometimes that's why I say it always. I use my visual assessment, then I look at the biplane disk summation method. Does it correlate? Does it make sense to me? Then I come to compromise and I have to track it myself again. Maybe the endocardium was not tracked the right way. Maybe they are tracking non-compacted myocardium.
منصور على الوقت يعني الصراحه فيري جود بوينت، وبنعلق عليها على السريع باش نمشوا لأسامة، وفي دكتوره نجدة عندها السؤال نمشوا لها على النقطه هذه باش نغطوا اكثر من نقاط. على النقطه اللي قلتها انت بالنسبه ان using السيمبسون biplane you have to make sure it was done accurate. Always your visual assessment لأنها experience. يعني I think we all agree لما ejection fraction normal 65 for more we all can tell. If ejection fraction is severely reduced less than 30% we all can tell. At 30-40 range sometimes it's challenging, so the more you train your eyes, okay, it's better. وفي data showed that using a Simpson biplane it does improve the inter-observer variability. Inter-observer variability اللي مش فاهمين عنها فكره ان انا نشبح ejection fraction نقول هذا 50-55، يجي دكتور منصور يقول لا هذا 60-65، يجي دكتور اسامه يقول لا هذا 45-50 وهكذا. ففي variability عاده بالفيجوال استيميشن تتكلم انت around 5-10% change و up to 14 some data. في data showed when you use Simpson method اللي هي biplane اللي هي more objective way than the M mode that improve inter-observer variability, and that's also self-training. You train your eyes when you call a thing to me. This is look like a 60% ejection fraction. When you do it biplane, it came to be it's 50-55. So you know like you're more overrated. هذه نقطة مهمة اتكلم عليها منصور. الحاجة الثانية بقولها ال 2015 document اللي هي American Society of Echocardiography اللي هي دكتور منصور استمد أغلبية السلايد بتاعها منها كداتا. They advise not to use the M mode for ejection fraction. They're against using the M mode for ejection fraction لأنه has a lot of limitation. أسامة يرد تعليق على الموضوع ده ejection fraction بعدين ناخذ الدكتورة نجلة.
شكرا أيمن. طبعا زي ما قالوا زملائنا واحدة من ال weak points is if you have ischemic heart disease and regional wall motion abnormalities. Another one I'd like to add is conduction system disease. So for example, if you have bundle branch blocks or paced rhythm, that can also affect your measurement. Now, when I was training 100 years ago, we did have to calculate the fractional shortening, both on M mode and 2D, and we had to get similar numbers that kind of went along together, but because otherwise there was something not right. So they made us do it, but at the same time they told us that the M mode measurement is not very accurate, but you just need to know how to do it. But obviously, ideally, the Simpsons method. The problem with Simpsons, it's also difficult to perform depending on the quality of the image and the person who's tracing and the person who's scanning. But nonetheless, with time, with practice, in patients who have good images, the values of the left ventricular ejection fraction are similar, and it is a better method than the using M mode for sure.
شكرا أسامة. شكرا دكتورة نجلاء، تقدر تديري انميوت وتفضلي سؤالك. شفت انت عندك
السلام عليكم.
وعليكم السلام.
أنا ask about the ejection fraction other method يعني بال quantification rather than بالسمسون or بالM mode. في new application اللي قاعدين حتى في الماشين اللي هي نستخدموا فيها نحن نيوز يعني تو نستخدم فيها حقيقة هي automated ejection fraction.
اي ميثود تستخدم في على 3 دي بال 3 دي اوتوميتد 3 dimensional.
Yes, it's a 2D. Yes. فهذه حتى هي very nice calculated و very easy. فحتى هي أنا حتى هي reliable وتعطينا more يعني accurate ممكن حتى بالسامسون يعني. فمانيش عارفة إذا كان في هي نص حد discussion عليها البوينت هذه.
لو أنت تحكي على لو تحكي
هل هي من البيزك أو ممكن هي من الأدفانسد بيزك يعني.
أنت لو أنك تحكي على is this في الفيليبس ماشين ولا السيمنز؟
Yes.
Philips. الفيليبس they have what they call the heart model. وهو يعني basically they have like thousands of database, different shape heart like the banana shape, the globular shape, the normal shape. They use يعني tracking system, speckle tracking. They can automate the ejection fraction. وعلى فكرة حتى left atrial size. It's I think in the future this is evolving. It will be very easy to calculate the ejection fraction. It's like a more 3D model. technology على transthoracic. it's future صح. بس هي النقطة يعني إنه اللي want to stress out إنه to avoid using the M mode for ejection fraction. It has a lot of limitation and it's not recommended يعني بال guidelines. We want to keep up with the
automated not recommended.
الام مود not recommended. الام مود
yes لا نحكي على الايتو مود automated ejection fraction.
لا لو هي 3 دي وتحكي على 3 دي فوليوم يعني it's recommended. the only issues ما فيش still verification data يعني they have to convert بالMR CMR هو الجولد ستاندرد for ejection fraction. فالفيوتشر بالنسبه للموضوع هذا الاوتوميتد ejection fraction I think it's going to be very promising وحتكون easier حتى للفيزيشن to get an accurate assessment. صح كلامك مظبوط.
yes very easy مش عارفه هي فيها advantage على سامسونج مانيش عارف
لانها 3 دي. منصور تفضل.
النقطة الوحيدة اللي بنعلق عليها the only point I want to add just make sure because when we say it's automated method it is not a new method. Automated maybe because I know even by plain disk summation method it could be automated meaning the word automated means the computer is doing it for you but the computer at the end of the day as mentioned earlier it has to use a mathematical calculation how to come up with ejection fraction and one of those we said the recommended one biplane disk summation method and the way that how does it come. So when it was automated I know it does exist too. The tracking of the endocardial border the machine do it for you. So do it the machine recognized by the EKG where is end diastole, where is end systole, and it will track the endocardium and then subsequently will calculate the ejection fraction for you. So you call it automated method but using biplane disk summation method.
على فكرة يا منصور ممكن ترجع للسيمسون ميثود بتاع التريسنج اللي انت شو ده. على البوينت على الدكتورة نجلاني قالت very good point. يعني بقول لك مثلا if you show us that Simpson method tracing في newer technology now to calculate اللي هو automated calculation of Simpson method they use the 3-point method. يمكن لو لبنى ولا سامع علق لها اللي هي فكرة مش عارف انتوا لو تشوفوا الماوس بتاعي على السكرين خلينا نحطها annotation مش عارف وين. ايوه منصور تحط 1 على الانيلس 1 دوت على البوستيريور انيلس 1 على الايبكس 1 على البوستيريور you click a button the machine itself you know systole with diastole would trace the whole LV size. You don't have to trace يعني في الايمج هذه مثلا اغلبيه الماشين اللي حاليا اللي بنستخدموا فيهم what they do they trace هذا الاصفر they trace it. بس النيو تكنولوجي 3 dots. فهذه automated method هي still the same concept. It's just like an easier way to do it, make it easier for a physician. لبنى عندك تعقيب على النقطة هذه بالنسبة مش عارف أنت in your lab what do you use? Do you use a tracing?
Yeah. Well, here's the thing. I actually use all of this stuff. Now I find the auto EF method it's not really accurate. I do not prefer to use it. I like to do Simpson tracing by myself, but let's say you have a nice crystal clear images. There's nothing wrong with that to use. All what you need sometimes the machine does the tracking for you, but you can adjust the tracing. you cannot just trust the machine. It does not trace it right all the time. And here's where we have, like a different EF. It's like visually, as the doctor said, you see it's like 40%, and then you give me 60% because the tracing is not right to start with. So you have to know what you're looking at to, to get a good and accurate measurement. But personally, I do not prefer using it. I prefer Simpson or LV volume.
ممتاز. تو انا اخذنا وقت هلبا اظن نختموا، لكن في سؤال مهم من دكتور رجب اللي هو قال اول حاجه تكلم عن البارادوكسيكال والموشن في الافكت ريزلت بتاع ejection fraction في السيمسون. لما يكون عندك مريض patient who has a paradoxical wall motion مثلا for example left bundle branch block, how much that affect السيمسون Mansour?
Yes, it does affect the Simpson, but again, as I said, like you have to use your clinical now your visual assessment. Incorporate your visual assessment when you make the ejection fraction measurement. I'm not sure what about others. What do you think?
دكتورة حنان مقرحي شو تعليق على النقطة هذه؟ لما يكون عندك wall motion paradoxical تأثيرها في ال ejection fraction assessment.
هذه واحدة من الحاجات اللي فعلا we face a lot of problems with the M mode. So we have changed completely from M mode to that symptom by volume assessment. I don't think it makes a lot of difference between if it is there or not. So it is more accurate for that group of patients especially.
Usama?
Great question. So as we know, conduction system disease, especially in the left bundle branch block, can significantly affect LV function. And we see how much improvement there is sometimes when we put CRT devices to improve the LV ejection fraction. So, patients can go from 30% to 50%. And so it can affect the ejection fraction significantly. And that's when, like Mansour said, you have to use your visual assessment as well, and not necessarily just rely on Simpsons, but Simpsons will be reduced as well.
Yes, أنا مثلا أعطيك my personal experience مع Simpson. If the 2D images are good quality, if tracing is accurate, I trust it. This is what I put in my report. Okay, and most of the time it's what fits with my visual estimation. If I don't believe this was done accurately, well, image is terrible, I don't use the pipeline Simpson. The point that I try to make, and you have to build up your own experience. None of these methods are accurate or perfect, so it's going to collaborate more than one element. I think the expert panel ودكتور منصور كلهم agree معي اليوم إن الM mode it's not the most reliable way of assessing ejection fractions. A lot of limitation. It's not recommended. النقطة الثانية في السنة دكتور جابو سؤال ممتاز جدا. قال ان الايجكشن فراكشن very important في our practice بالذات المرضى اللي عندهم heart failure مثلا EF less than 35%. هل احنا افضل ان احنا كونفيرم الميجرمنت باذر ميثود مثلا زي السي ام ار؟ انا نقول لك الكومنت بتاعي بعدين نختموا على الاكسبرت بانل على السريع ونختموا مش نعطوا هلا. بصفة عامة if the whoever did the echo ولا read it experienced physician, I can tell you can tell this ejection fraction less than 35% or not. يعني experience play a huge role. مثلا نقول لك in my own experience I think I maybe have sent 1 or 2 cases for a CMR for maybe ejection fraction. حتى when I send CMR I'll make sure I send them to someone who's good at it, who knows how to read it. لأن ال CMR الكاردياك MRI is very technically challenging. I do trust my own assessment. And the other thing, I ask some of my colleagues, مثلا نكلم منصور وأسامة شوف ejection fraction الإيكو. What do you think? I get more input, 4 eyes more better than 2. ربي يعطينا عينين لسبب معين باش تعطيك more information. You can ask for help, بس you don't have, and in my personal experience, I don't send every single patient when I think in the ICD range to send them. مش عارف خلينا نبدأ بمنصور.
Yeah, I totally agree with you. And maybe we had the luxury of using contrast right now for better assessment of the ejection fraction. and even would reduce significantly. Think about MRI. Rarely, I don't remember like to just have accurate assessment of the ejection fraction, you will send someone for cardiac MRI. Okay. And personally, I always say it, I don't treat numbers. I know numbers are important for ICD or CRTs or anything like that, but it depends. The ejection fraction is not LV contractility only. As I said, it depends on the preload, afterload, and what is the condition at which you measure the ejection fraction. And if needed, I use contrast, but rarely MRI.
على فكرة منصور منصور غير الوقت ما سدناش، لكن you brought very good point. The use of contrast agent يعني I know unfortunately مش موجودة في ليبيا، وإن شاء الله في future we see it. But it's a great tool, make your job is much easy on some of those, you know, because some patients they have body habit is very to assist. لبنى شو تعليق على النقطة هذه نتاع low ejection fraction?
Sorry, Dr. Ayman, I wasn't listening. What's that again?
لو لما يبدأ ejection fraction less than 35%، يعني هل can we trust الإيكو ولا should we do a different method؟ لأن المريض حيكون need an ICD ولا باي بي. ومنصور علق على نقطة الكونتراست ايجنت، فأنت شو تعلق على النقطة هذه؟
Yeah. Well, it depends on the image quality here. It's all depends on that. So sometimes, I mean, if it's severely decreased, definitely we do use the contrast to make sure we're not missing anything on the bottom of the heart and the apex, you know, blood clot or anything. But if it's 35, for me, and I do have a good image quality, I don't usually or not often use Definity. So it is, I mean, if my image is good enough for the doctor to make assessment, then I don't. But if my image it's not good enough, then I do use the highlighter. Let's just put it that way.
لبنى انت do you see the screen now?
I do see the
خلاص رايكم في الاكسبرت بلد نسلكم بالواحد والحضور الايكو اللي حاطه منصور. How much would you call this ejection fraction؟ والناس اللي يسمعوا فينا كل واحد.
Oh no, you're not gonna start with me. No, we're not gonna do that.
أسامة أكبر واحد خبرة. أسامة. إحنا قلنا ladies first يا لبنى، لكن هاي أسامة.
So this to me, I would say
not normal. Let's agree.
I'd say 20 to 25%.
طيب خلاص. منصور.
I did answer already before Osama mentioned, so I don't get biased. I wasn't say 25%.
خلاص.
I wasn't. Yeah.
باي دكتورة حنان.
Even below 30.
Below 30. في دكاترة قالوا 30 ممتاز. أنا نقول لي 25-30 at the most.
Exactly. I agree with you.
في consensus. I think this would be a great end of this excellent, outstanding lectures. شكرا منصور، أبدعت، بارك الله فيك. شكرا دكتورة حنان على الانبوت بتاعك. دكتور أسامة، لبنى كالعادة متميزة. شكرا للدكاترة. طبعا هذه حتكون موجودة متسجلة في اليوتيوب channel. إن شاء الله في المستقبل نحاول نديروا كيسات interesting cases echo. We meet, we discuss them. يعني something very informal. بالذات الناس اللي عندهم interest echo. بدنا بينا نشوفوا كيسات من ليبيا. مشكورين، شكرا، بارك الله فيكم.
أيمن just كلمة.
تفضل، نعطي كلمة تفضلش نختمه. تفضل.
General, there's nothing wrong with saying a structure cannot be assessed and you cannot see it accurately. Do not comment on a structure in your report if you can't assess it accurately. Just say it's not well visualized, because any information you give has clinical consequences.
أسامة هذه نقطة مهمة. It's okay إنك أنت توري الإيكو لحد ثاني.
Absolutely.
عادية جدا. يعني أنا تو يعني قديش لي ندير ونبعث نكلم في دكاترة معي، في دكاترة بروفيسورية معي يعني كانوا متخرجين من الطب قبل حتى ما نولد أنا، ويبعثوا لي في إيكو وشوفوا it's okay يعني get different set of eyes. الناس يعطوا different opinion.
أصدق كلامك يا أيمن يعني فكاهية حاجة شوية. مرات لما نمشي للجماعة اللي قروني الإيكو نقول له ترى شنو الميجرمنت هذه، فيدير في ميجرمنت نقول له وين الأجل اللي تشبه فيها؟ يقول لي I have special powers. خلاص ما عندش كيف. بارك الله فيكم، شكرا.
دكتورة حنان كيف بتعاقبي قبل ما نختموا؟
يا دكتور بس نقول شكرا للجميع وبارك الله فيكم.
لبنى.
شكرا بارك الله فيكم. Thank you so much guys for including me in this such a great presentation. Thank you.
شكرا بارك الله فيك. منصور ختامها مسك معك انت ابدعت، تفضل.
شكرا للجميع وشكرا للحضور، وان شاء الله نلتقي عن قريب في ليبيا ونكونوا في ورشه عمل regarding الايكوكارديوغرافي باذن الله.
ان شاء الله عندنا تو ان شاء الله باذن الله بنغازي اكتوبر 26 ل 28. دكتوره حنان المقرحي بارك الله فيها، هي اللي تقول هي اتس هير ايديا وشي بوتينج ا لوت اوف افورت. ان شاء الله حيكون ورك شوب دوره مميزه بكل معنى الكلمه باذن الله. السلام عليكم وشكرا جزيلا، بارك الله فيكم على الحضور وكلامكم الطيب. نشوف رسائل، مشكورين جدا.